Bismillahirrahmanirrahim. Assalamu alaikum. My name is Dr. Bakht. I am the registrar in the Department of Internal Medicine in the Islamabad International Hospital. If you are not a medical student or a physician, then this discussion is not for you. I am going to discuss with you a very interesting case. So it's for the medical student and physician. I got a patient, a male patient, who is 30-year-old about 2 weeks ago, and he was complaining of mid-epigastric discomfort, mild in severity. Interesting points in his history are he was complaining of mid-epigastric discomfort about 6 months ago. It was mild. He went to a gastroenterologist and he advised some investigation, including the baseline investigation, CBC. His HB came to be 9.4 and his MCV was 49. Then the gastroenterologist advised the FOBT, the fecal occult blood test. It came to be positive. As the low HB level was disproportionate to his symptoms, he was having only mild epigastric discomfort. He was pale in clinical appearance, but his symptoms were very mild. On the other hand, FOBT was positive. The gastroenterologist put him on iron supplements and he refused to do the endoscopies because the symptoms were very mild. He put him on PPIs, the esomeprazole. The patient got okay with the medications and the gastroenterologist put him on iron supplements, and he was told, according to the patient, that the gastroenterologist told him there is no need to come back. He will get okay with iron supplements. Now, 6 months later, he came to me and he was discussing his problem that he is having fatigue. He is having mild epigastric discomfort for the last 4 days, but he is having continuous fatigue. On examination, he was pale. His conjunctiva were pale. He was not having any organomegaly, and his systemic review was not significant. In general physical examination, only he was pale and his conjunctiva was pale. Otherwise, no organomegaly, and his cardiovascular system was normal. No positive findings in the GI examination. In the clinical history, in the family history, we came to know about very important points. He was having positive family history of thalassemia. According to the patient, 2 of his cousins died of thalassemia during childhood. So it was thalassemia major. We were not suspecting thalassemia major in this patient. By profession, he is a police soldier. He was pale, but he was not having the appearance of thalassemia patient. No bossing appearance of his maxilla, his forehead, although he was very anemic, very pale. He was not having symptoms of ulcer, the gastric ulcer, because he was having very mild discomfort. With PPIs, he became okay 6 months ago. Now again, for the last 4 days, he was complaining of very mild discomfort. According to the patient, it's not so much bothering. There was no gross blood. There was no hematochezia, no gross blood in the stools. But FOBT was another confusing point. FOBT was positive, but the gastroenterologist refused the endoscopies. Now, I repeated the CBC again. It came to be 9.2 again. The 6 months ago, it was 9.4. His MCV was 49. This time, his HB is 9.2. MCV is 55. Peripheral smear show hypochromia, and they also described some teardrop cells. I discussed the case with my friend, Dr. Hamid, who is a gastroenterologist. And he said we will do the HB electrophoresis. And if it is negative, it means if electrophoresis was normal, then we will schedule upper and lower endoscopies. At the same time, I discussed this case with my friend Dr. Tariq Masood. He is the assistant professor of hematology in the Northwest School of Medicine. He is PhD in hematology. And he told me directly that it is very interesting scenario. And he said very important points for the medical students and for the physicians. He said that TT, thalassemia trait, is coexisting with iron deficiency anemia. Before the HB electrophoresis, he told me this because he's an active researcher and he has been the director of Thalassemia program in Peshawar. We did the HB electrophoresis. It came to be TT, that is thalassemia trait. I called Dr. Tariq and he said that we have to postpone the endoscopies. Although the FOBT was positive, the fecal occult blood test was positive, but the symptoms were not severe of gastric ulcer. The patient having severe pain radiating to the back, and it is very bothering. So the HB electrophoresis showed that he is having thalassemia trait, the TT. Now we are going to send this patient to Dr. Tariq for further evaluation and also to put him on the medications, the iron supplements. We can do that, but as they are more expert in treating patient with thalassemia. Normally we say thalassemia trait, like initially what I thought thalassemia trait is not causing so severe anemia. So one confusing point. Other thing is that if he is having gastrointestinal bleeding, that is the microscopic bleeding, as he was not having any gross bleeding in the blood. We were not suspecting any ulcerative colitis or any other problem which can cause gross bleeding, and he was not having history of gross bleeding. Then how the HB is so low? We were not suspecting the gastrointestinal bleeding because of very mild symptoms. So these are very important points for the medical students to learn and for the physicians to always discuss such cases with colleagues who are expert in the same field. According to this patient was seen by the gastroenterologist 6 months ago. The gastroenterologist refused endoscopies because of very mild symptoms. He was not suspecting gastric ulcer. And according to the patient, he was told by the gastroenterologist that there is no need to come back and he will get okay with the iron supplements. Now, after 6 months, when I repeated the CBC, the HB again was 9.2. The MCV again is 55. He never did the HB electrophoresis in the last 30 years. Now, it's not for the last 6 months. Only he went to the doctor last 6 months ago. He might have this problem for many, many years. And he is a police soldier. I was so much surprised how he's performing his duties with so low HB level. So very important points for the physicians to decide in the best interest of the patient. They must discuss the cases with their colleagues, with the whole panel, because anemia can cause so many problems. One, daily activities are very difficult. Low HB level, low oxygenation. It can lead to MI, myocardial infarction. It can lead to ischemic stroke. It can lead to many more problems. So now what we will do, we did the HB electrophoresis. I'm going to send the patient. I have already discussed the case with Dr. Tariq, and he told me to put him on the iron supplement, but I'm going to send him because he's more expert than me in treating thalassemia. Then I googled many research articles with the title TT, Thalassemia Minor Association with the Iron Deficiency Anemia, and very interesting articles popped up that iron deficiency anemia is coexisting with thalassemia trait. Normally we say thalassemia trait doesn't cause anemia, but because of the coexisting iron deficiency anemia, the patient can be anemic. But he was not okay with the supplement. The supplement might be low, not enough to replenish his iron stores because the MCV was so low. So the important points here are learning and also advice to the physicians to discuss such cases with their colleagues who are more expert in their field. I hope you enjoyed this discussion, you learned from it, and from this experience, I hope that all the physicians will discuss their cases with the whole panel. Thank you so much for listening. Bye bye. Assalamu alaikum wa rahmatullahi.